Welcome everyone. Thank you for participating in today's webinar, where we're going to be looking at a relatively new issue that is of growing importance to you and your patients. We'll start with some background on both onychomycosis and terbinafine. We'll get into the specifics of the mechanism of action of terbinafine and how resistance occurs. We'll then look at some current epidemiologic trends, and finally we'll look at various laboratory testing options and how they can be useful for you in your practice. We're all familiar with the problem of antibiotic resistance. You have overuse and misuse of antibiotics, and that leads to resistant strains, which can then be very difficult to treat. But this doesn't just happen with antibiotics. It also happens with antifungals, and that's exactly what we're seeing with terbinafine now. We'll start with a basic case study. This is the kind of thing you see in your practices all the time. This was a 53-year-old female. She had long-standing nail dystrophy and had already failed 2 courses of oral terbinafine. Histologic examination identified fungal elements, and additional testing was done on this patient, and we'll get to the results of that a little later. Here's some basic background information on onychomycosis, information I'm sure you're all familiar with. Up to a quarter of the world's population deals with cutaneous fungal infections of some sort, and 5.5% of the world's population has onychomycosis. The patients who are at increased risk, the elderly, the diabetics, and there can be significant morbidity associated with this, including ulcer, secondary bacterial infection, and even loss of digit. So in the broad heading of onychodystrophy, we know that about half of cases are due to onychomycosis, and the other half are due to a very long list of possibilities, most commonly trauma and onycholysis. And that's where laboratory diagnosis can be helpful. We can use histopathology, as we saw on the previous slide, and we can also use PCR and culture, and we're going to talk about that a little later. And you all know that onychomycosis is very hard to treat. These nails are composed of dense layers of keratin, and it's very hard for the topical agents to get in there and do their job. If you choose the oral medications, then you have to deal with the fact that the nail grows very slowly and you have to wait a very long time to see if you get a good clinical result. And antifungals are known to have side effects, particularly with the liver, and we're going to talk about antifungal resistance today. A little background on terbinafine. It is an alloamine antifungal. It's been around since the early to mid-90s, first available as a topical and over-the-counter, and then later as an oral, which was by prescription, and this was a fantastic drug. It was broadly effective, it concentrated very well within the nails, and it quickly became the treatment of choice. This graphic shows the mechanism of action of various antifungals. Terbinafine and the alloamines are here, and along with the azoles, they act to inhibit the production of ergosterol, which is a key component of the cell membrane. If we zoom in a little closer, we can see the series of reactions that's involved in production of ergosterol, and terbinafine acts right here, where squalene is converted to linosterol, and that is potentiated by an enzyme, squalene epoxidase. And if we look even a little closer, this is a 3D rendering of the squalene epoxidase protein, and we know that terbinafine plus a cofactor bind at a very particular site, and there are specific amino acids that are essential to that binding. Once it binds, 2 things happen. We get decreased production of ergosterol, which can lead to cell death, and you also get buildup of squalene within the cell, and that also causes cell death. So it causes it by 2 mechanisms. So we have a great drug, and it seems to work, so it's time to celebrate, but not so fast. As Dr. Ian Malcolm warned us in Jurassic Park, life tends to find a way, and that's exactly what's going on with the dermatophytes. They're crashing through our barriers and finding a way to persist. So I'm going to review a few articles to show some trends over the years in terbinafine resistance. Everything was going smoothly until 2003, when we had the first documented report of terbinafine resistance in dermatophytes. This was a U.S. study. It was done with 30 patients. They all had documented T. rubrum, and they also had terbinafine treatment failure. They did serial culture and sensitivity testing, and they had one patient who was confirmed to have terbinafine resistance. This is just speculation, but the reasons the others couldn't be confirmed to have terbinafine resistance could be due to the inherent difficulties associated with performing fungal culture and sensitivity, which is something we're going to talk about a little later. This table shows the MIC of the patient samples versus reference strains. The bottom, you see the reference strains had very low MIC, down to 2/10,000ths of a microgram per milliliter, whereas this patient samples showed high MIC indicating resistance. They went a little further and they looked at some other drugs that act at Squalene epoxidase, and this table is laid out a little bit different. We have multiple topical options here, and for each drug, the first two lines show the patient samples, and the third line shows the reference strain. And we can see that the MIC remains low on all of the reference strains, and it was high on all of the patient samples, indicating resistance. They looked at the other side of the coin. They looked at other antifungals that have different mechanisms of action. And here we have itraconazole, fluconazole, and griseofulvin. And what they found was that the MICs for these remained very low. So they did not see resistance here. And now we're going to fast forward and go all the way up to 2020. And here was a study that was done in India. Data was collected from 2017 to 2019. And as the title suggests, they had some somewhat alarming findings. So they had 400 patients, and they were spread about India, and they subdivided the data into north, south, west, and east regions. They surveyed these patients before the study and found that around 80% of them had self-treated prior to seeking medical attention. And in India, medications are not as tightly regulated as they are in the U.S., so they have a lot of medications available to them. They were using both oral and topical antifungals, corticosteroids, antibacterials, and they saw a troubling amount of use of what they called fixed dose combination, where you have, specifically, you could have an antifungal combined with a high dose of steroid, and that's particularly problematic because, for one, it's not very effective, and number two, you're suppressing the patient's immune response while exposing them to an antifungal, and that's a situation where you can get an emergent strain that's resistant. So this slide shows the strains that were found in various areas of India, and interestingly, you can see the T. rubrum in green, circled in green, which has traditionally been the most common, now accounts for a very small percentage of the infections. And in contrast, we have T. Mentagrophytes, a particular type that they identified as ITS type 8, is in black, and it is now causing the vast majority of the infections in India. So why is that happening? Well, when they looked at resistance patterns, they found out that this T. Mentagrophytes type 8 was resistant from 75 to 77% in parts of India. It was somewhat lower in the south, down to 16%, but that's still a very significant percentage and higher than we've seen elsewhere. So they looked at the DNA sequence of these strains to see what was going on, and what they found were there were missense mutations in that squalene epoxidase gene. And just as a refresher, these mutations, you can see here the top strand is a wild type or normal DNA, and then you have a mutant along the bottom. And you can have the exact same series of nucleotides with only one substitution, which here is like a thymine to an adenine, and that one substitution can lead to a different amino acid being produced. And that one amino acid difference can alter the protein so that it then has different chemical and physical properties. We see the terbinafine binding sites, we see the specific amino acids that are involved, and they could actually identify the specific mutations that were going on here. So at site 397, we got a phenylalanine that then became a leucine. At site 393, we can see a leucine was then substituted out for a phenylalanine or serine, and that's enough to change the binding properties. And there were others that were reported less commonly. So what are the reasons behind this increased terbinafine resistance? Well, we know there's broad antifungal use. They're widely available everywhere. And onychomycosis is often treated empirically, even though we know that half of the cases are due to other causes. Additionally, the over-the-counter antifungals that are combined with steroids can also suppress the immune response and contribute to the rise of resistant strains. All of this leads to a selective advantage for the development of a resistant strain. So this was all happening in India, and it would be great if it was just there. But as we know from COVID, these things don't tend to stay localized very long. And indeed, we're seeing it spread already. And if we go to this European study in 2020, they looked at 20 countries, and they found out that 17 of those countries were having antifungal resistance. 2 did not respond to this study, but published their own data separately that showed antifungal resistance, and only 1 reported no known resistance. You can see the countries in orange did report antifungal resistance. Germany and Poland there didn't respond to that study, but they had their own data on antifungal resistance. And it looked like only Hungary reported no known resistance. So if we zoom in on Germany, we can see that they published data in 2020. And they look specifically at the T. Mentagrophytes type 8 that we saw in India. And what they found was that it was getting spread in different parts of Germany. And they also were able to identify the similar Squalene Epoxidase mutations. And you can see that it's not isolated to any one area in Germany, it's kind of spread all over the country. Now we're going to take another trip to the island nation of Japan. And even though it's a little more isolated, they are already seeing resistance there. This was a 2021 study, and they looked at 210 cases and found that 2.3% were terbinafine resistant. And in contrast to the German study, in this study, all the cases were T. rubrum. And it turns out around 4% of the T. rubrum cases were terbinafine resistant. And again, they evaluated for the mutation and found a common mutation in all these strains. So we know now that terbinafine resistance exists and appears to be growing, but do we need to be testing our patients for it? Well, we already know that we have a common problem, a difficult problem to treat, and now we can throw into the mix that we have increasing terbinafine resistance. So what can the testing get us? Well, we can find out up front if we have a terbinafine resistant organism, and that allows the clinician to select an agent that may be more effective initially. And you avoid the prolonged delays when you have the wait and see approach of treating and waiting for several months to see if you get a clinical response. If the organism is terbinafine sensitive, then we can go ahead and treat with confidence. So this should all lead us to getting better patient outcomes and happier patients. So if we're going to test for terbinafine resistance, how are we going to do it? We can use modern PCR molecular methods, or we can use culture and sensitivity. I'm going to talk first about culture and sensitivity, and I apologize, this is a complicated slide, but that's partly because the underlying process is so complicated. The area that you see boxed in red is the culture portion, and for that, we have to make sure we get proper collection and transport of the specimen, and then once we get it, it takes several weeks for it to grow, and you always have to worry about bacterial overgrowth or saprophytic fungus overgrowth, and the results can be affected by the patient being on antifungal treatment. And so once you've done all that, if you decide to go on and do sensitivity testing, you have this other whole series of steps outside the box that still have to be done. So this is a very long, difficult process. So it seems like there should be a better way. And since we're in the 21st century, we have modern PCR molecular methods. And just as a reminder, in PCR, it's a pretty straightforward process. We take a double-stranded DNA, we separate that into 2 individual strands. We then add some primers and some nucleotides, and then each of those daughter strands goes on to form another double-stranded DNA. And so from 1 you get 2, and then you just repeat that process multiple times. And by the time you get to 30 to 40 cycles, you have millions and millions of copies. And so what we can do is add a probe for the squalene epoxidase mutations that we know are causing resistance. So how does PCR stack up against culture and sensitivity? Well, as we already discussed, specimen handling and contamination issues are huge for culture and sensitivity, and they're not much of a problem for the PCR. PCR is also excellent at detecting very small quantities that you would likely never get to grow in culture. The process for PCR is basically one step, and for culture and sensitivity, you're looking at numerous steps. And with all those different steps, there's more room for the growth to fail and not get a result. PCR is also not affected by prior antifungal treatment. And so your turnaround time for PCR is about 2 days. For culture and sensitivity, you're looking for up to 6 weeks for just the culture part, and sometimes even more to get the sensitivity. You may recognize this poster if you were at the APMA in Denver earlier in the year that was based on the development and validation of that test. So this was the mutation detection panel, and we looked at 4 particular sites on the Squalene epoxidase gene, and with those 4 sites we could look at 12 different mutations that are associated with terbinafine resistance. We were able to do that in 4 reactions versus 12, which cuts down on the amount of testing that needs to be done as well as the cost. This is an example of the PCR output that gives you your results, and you can see the horizontal red line shows the limit of detection, and anything above that is positive. Higher concentrations will just cross over earlier, and we can detect lower amounts also. They just take a few more cycles. This is another amplification plot. This one deals with the topic of mixed infections. So you can have a mixed infection in 2 ways. You can have 2 different types of dermatophytes or 2 different strains infecting one patient, or you can have the emergence of a resistant strain within an existing infection. And what you can see here is that we can detect when there's only as little as 1% mutant strain present. This is the data from the validation studies. There was a mixture of clinical nail specimens and known terbinafine-resistant isolates from reference lab. And it was determined that all 35 cases that were positive by culture and sensitivity were also positive by PCR. Likewise, all 246 that were negative by culture and sensitivity were negative by PCR. The study also looked at the rates of terbinafine resistance in this population, looking at 1,300 clinical samples, found an overall mutation detection rate just under 4%. For T. rubrum, it was just over 4%. So returning to our case study from earlier, the patient with long-standing nail dystrophy had failed 2 courses of oral terbinafine, was found to have a fungus on histology. So what else was found? A PCR screen identified T. rubrum was present, and a subsequent terbinafine resistance panel identified a mutation that we know to be associated with terbinafine resistance. So now this allows the clinician to select a more appropriate therapy, get a better patient outcome, and hopefully have a happier patient. In summary, onychomycosis is a common problem with significant morbidity. Treatment has always been very difficult, but is getting even more so with the increase in terbinafine resistance. We're seeing very high amounts in certain parts of the world, at least 4% here in the US, and likely on the rise. So laboratory PCR testing is available that can help identify terbinafine resistance. Those results can be obtained rapidly, and that can allow clinicians to provide more targeted treatment and better patient outcomes. That concludes the webinar. I thank you for your attention, and my dog Ellie is very happy that you participated today.